Don Ponec is my associate at American Access Care and one of the physicians in the lead of the Hubbard trial. I've asked Don to discuss the trial and to give us his outcome results in a preliminary way for the patients.
From your lunch too long here. I'm Don Ponec. I'm from San Diego, California. Wanted to talk to you about the outcomes of liberation procedure, so-called liberation procedure. Is this echoing or is this okay? Can you guys hear me? Yes. Okay. No? This? Okay. So liberation outcomes. First thing is I don't have anything, no financial relationships to disclose. The definition of to liberate is to set free, especially from imprisonment or oppression, and that's kind of what I think, at least in my experience, some patients with multiple sclerosis are experiencing, a sort of imprisonment by their disease. I think, unfortunately, that's a tough term because it implies that there's a one-time fundamental shift that happens with the so-called liberation procedure, leading to a sustained change in status. And I don't know if that's really going to be what this turns out to be. It seems more likely that the CCSVI treatment will be more of a process, one of many, leading to improved disease management and quality of life. So we're all familiar with the idea of the pathophysiology. That's localized venous hypertension causes delayed perfusion. A few things happen, and the net effect is myelin degradation and plaque formation, and then the clinical symptomatology of multiple sclerosis. And this is the venous anatomy that we were hearing Dr. Hickey talk about earlier today, and certainly as an interventional radiologist, mainly dealing with arterial structures in the head and neck up until the last couple of years. This always seemed like a fairly straightforward thing. Venous anatomy, you know, it's sort of just how the blood gets back to the heart. It's not really the business end of things. Probably nothing further from the truth. You know, when you think about it, and I think this is one of the reasons our colleagues have a hard time with this, because they think of the venous return as maybe a stream going down a valley. You know, you dam up an area where the stream normally flows, well, the water just finds its way around. And so as a consequence, it's hard to conceptualize why that would cause this disease or a disease. And it's probably more like what we see in the legs. You know, we treat venous insufficiency in the legs all the time, and we know that when there's venous hypertension, when there's reflux, this creates pathology in the skin of the legs. We see thickening, we see blood that leaks under the skin, we see iron deposition, this brawny discoloration, even ulcers, inflammatory changes. So it's not that big of a reach. Now, we treat it totally differently because there's a refluxing vein that we just occlude, but in this case, in the so-called CCSVI case, we're opening up venous outflow to prevent that kind of pathology. So it does kind of correlate with what we already know about venous disease, but in kind of a different way. As we know, the CCSVI indications are the presence of a hemodynamically significant venous stenosis or flow abnormality by MRV or by ultrasound in patients with multiple sclerosis, question mark other neurologic diseases. And that is CCSVI and MS one-to-one? Is it another type of process that's layered on top of the symptomatology of MS? And are there other things that were alluded to earlier that CCSVI might apply to? In the literature, Dr. Zamboni published the still, I think, one only published clinical outcome study, 65 patients. You can see the distribution, roughly half relapsing and remitting disease, and statistically significant benefit at follow-up. So this is the one article in the literature. And this is, despite this relative paucity of literature, there's a ton of this work being done. There's a lot of provision of CCSVI treatment in the private community, and this led to a position statement by the Journal of Vascular Interventional Radiology that encouraged us to do research. And we realized that a randomized controlled trial, that's the coin of the realm. That's how we in medicine feel confident that we're providing the right care for patients that's safe and clinically efficacious. Patients. And then over on the right, the percentage, it's 64.9% female, and then 53.6% relapsing and remitting disease. Going the wrong, there we go. So the MSIS 29, this is a patient-generated survey. It's not administered by a neurologist, but it's been validated against other scales that are administered in that way. This is just an example. I won't go through this because you've probably seen it, but bottom line is it's a series of questions that are meant to be a look back over 2 weeks. So it kind of integrates fluctuations in day-to-day life over a 2-week interval, and we look at physical and cognitive functions. And just in a nutshell, these are the results from our trial. So what we're looking at is a histogram that shows the distribution of patients. This one is on the physical scores. And so you can see that the no change bar is in the center. The two to the right have statistically significant improvements. So the vast majority of patients improved. It was about 70%. Similarly, at 6 months, this is a preserved effect. On the mental health scale or the cognitive scales, the same effect here at 1 month and at 6 months. And so the net effect of all of this was that at both 1 and 6 months, there was a highly statistically significant clinical improvement in patients who were pre-qualified as having CCSVI and then underwent venoplasty, or in a few cases, stents. About 2.5% of our patients had stents. And so this is the second study that shows that after Dr. Zamboni's, essentially validating his initial predictions. The restenosis rate here, it's important to realize this 8.3% is probably an underestimate because this is a clinical restenosis. As Dr. Scalfani said earlier, people who become symptomatic again clinically, most often we are finding a restenosis in those patients, but we're not actively looking for it. And when a randomized control trial is done, of course, this would never satisfy the requirement. What we would do is periodically come back and do an active reevaluation, most likely an MR venography. So the summary of predictors, interestingly, and this kind of speaks to the idea of what we're going to measure in a randomized controlled trial, is what we found is that some of the things that we thought would make a difference in terms of who would respond and who wouldn't respond didn't really seem to make much of a difference. So MS subtype, we saw about an equal amount of response across all of the different types. And previously, the assumption would be, your ideal patient would be a young woman with relapsing and remitting disease with a relatively short disease duration. And that just really didn't turn out to be true. All patient groups appeared to benefit. The degree of disability, degree of CCSVI, if you will, the degree of stenosis or occlusion, didn't really seem to correlate all that well. And so, in summary, just to kind of keep us on time a little bit, second report of statistically significant clinical improvement using a validated clinical measurement tool. Again, the restenosis rate here is clinical. The reported restenosis rate in Dr. Zamboni's articles was 50%, although the balloon sizes typically used in his study were relatively small, by our current standards, so that may have contributed to maybe a little bit higher restenosis rate. We're kind of predicting it would be between the two somewhere. Future directions, I think better measurements of flow and venous anatomy, measurements of perfusion and diffusion in the brain, quite possible. Dr. Hickey is an expert in that, as well as with the BOLD sequences, which measure blood oxygen in the cortex. We'd like to know a little bit more clearly who's going to potentially benefit from these techniques and understand the pathophysiology a little bit better. Obviously, someone else in the back talked about other effects, and so again, my problem with the liberation procedure is that, well, you can just throw away your Copaxone. You don't have to worry about your diet or exercise or going to yoga or whatever you normally do. Not true. I mean, really, this is... Can you hear me? Oh, I'm sorry. It's not really true. You need to sort of stay the course and look at this as one part of your treatment for multiple sclerosis. Turn up the volume. Now you tell me. Okay. Well, we're almost finished anyway. So issues, I think this is a major issue that we have right now. This is where the provision of this service is getting a little bit ahead of the science. There's some commercial interests, centers that want to do this, not necessarily enrolling patients or studying their results, and they may not contribute to the scientific understanding of this process. We've had a registry now for a year and a half. I know Dr. Scalfani's just got an IRB approval for something that's starting up. But this kind of thing can lead to a lot of fragmented patient care, especially if there's a lot of travel involved in getting these procedures done. So more clinical studies. There are relatively few sites enrolling. There are several U.S. trials underway, as I just mentioned. Canada has funded 7 studies, all of them diagnostic. I just talked to Lindsay McCann up at University of British Columbia. He told me that the Canadian National Minister of Health announced funding for a treatment trial, and so now the universities are putting together their protocols and submitting them to see who's going to get funded for this. We know that in order to get the support of neurology and organized medicine, first we got to get organized. We need to kind of go about getting this information properly. But the neurologists and generally organized medicine is going to require that we provide positive results from a randomized trial, and that's really our next step. And so we're looking at options for that in terms of how we're going to fund it and how we're going to perform it.